Thank you, Dr. Kloblansky, and thanks to all of you for joining us here today for this virtual World Medical Innovation Forum. The only thing that's not changed over the last 3 months is that things are constantly changing. We are now in a world where just several months ago at the Mass General Brigham system, we delivered about 2% of our care virtually. We're now delivering nearly 60% of care virtually. We're now rethinking, what does a routine elective procedure mean? What does routine mean? In addition, we're thinking about how can we schedule patients in the future? What is the future of the waiting room? These are all important questions that all of us are now asking. And we wanted to take this opportunity today to hear from some of the leaders here in the Mass General Brigham system about their thoughts on these issues. I'm pleased that we are joined by John Fernandez, the president of Mass Eye and Ear, and the leader of the Mass General Brigham System's ambulatory care efforts. We're also joined by Dr. Betsy Nabel, the president of Brigham Health. And we're joined by Dr. Peter Slavin, the president of the Massachusetts General Hospital. Additional information on their bios are available to you through the links here on the site. Let me begin by asking a first question, and that is how much of this change is going to stick? Dr. Fernandez?
Thank you, Greg. Good morning, everybody. I hope a lot of the change sticks, especially the virtual part of it. I think there's great opportunities if we can use telemedicine, Zoom, or whatever technology to connect with patients from the couch to the office and pre and post-op. So I hope that's the one that stays, and I think it will. The other one that I hope continues is interstate use of telemedicine, so we can help patients in our region and do it efficiently and quickly. So I'll turn it over to my colleagues that might have some additions.
Dr. Nabel?
Well, thank you very much, Greg. And first and foremost, I want to express my gratitude to all of you who are joining us today for the tremendous support that you have provided us and our frontline care workers during this pandemic. Please know how much your support means to so many people who are working on the front lines to combat this crisis and to save lives. So thank you very much. You know, Greg and John, we're hoping that just a lot sticks. Greg, you referred to this. We don't even know what the new normal is going to be, but we know that the old normal is not going to be the new normal. And so we're really re-examining how we approach healthcare, how we think about healthcare. Everything is on the table. We know that we're going to be doing much, much more in the telehealth and digital space. We're going to be re-examining how we use all of our assets, bricks and mortars, and our workforce. And we're really going to be rethinking now, how can we make the healthcare experience better for our patients? How can we deliver care where they want it, when they want it? How can we improve access? How can we make care more efficient? And importantly, how can we lower cost? How can we lower that total medical expense, or TME, as we say here in Massachusetts?
Greg?
I'm going to move on to the next.
I might add one piece, is that the opportunity to redesign as we recover is a great opportunity as well.
Agreed. You know, one of the things that's been spoken about is this notion that one of the other tolls that this pandemic has taken is that we've not had the opportunity to make our care available to those who need it every single day. That fear or other factors are leading patients to avoid coming into our facilities for secondary care. Dr. Nabel, can you talk a little bit about what you're seeing and what you're trying to do about that?
Well, Greg, you're absolutely right. We know that during March and April, we really converted our hospitals to care for our COVID patients. And we did it beautifully. Our ICUs, our medical surgical floors, our ORs. But now we're getting back to our new normal. And in fact, the percentage of our COVID patients is only 20% of our total patient population. I want to reaffirm that our hospitals are safe. Our hospitals are probably one of the safest places where patients can be right now. And why is that? Is because we have implemented extraordinary measures to segregate COVID patients from other parts of the hospital and to use protective personal equipment, PPE, which we now have for all of our patients and for our healthcare workers. In addition, we're doing much more testing now than we did previously, both for the viral antigen as well as for antibodies. But having said that, we know that during March and April, many of our patients with heart disease, with lung disease, with cancer, with diabetes were simply afraid to come to the hospital. And so they didn't get the care they need. And now they're returning back to the hospital much sicker than if they had come previously. We did postpone our elective surgeries, but we even deferred some of our cancer operations. Those can no longer be deferred, and many of our cancer patients are now coming back for surgery, for chemotherapy, and for radiation therapy. Our cardiac catheterization lab, where we take care of people with heart attacks, was less than 50% occupied, whereas we know that in normal times it would be 100% occupied. So many people with very significant serious illnesses avoided coming to the hospital: heart attacks, strokes, cancer therapy. But the message now is hospitals are open, they're very safe. Individuals who do need care must come back to the hospital.
Dr. Slavin, maybe you can tell us a little bit about what Mass General is doing to try to get that message out and how you felt this impact of deferred secondary care.
Hi, Greg. My sound just came on, so I just heard the tail end of your question. But yeah, I'm sure, like Betsy and John, are concerned about the cases that we are not seeing, the decreased number of cardiac and stroke patients showing up in our emergency room. We've been calling out to patients who are in certain high-risk categories to try to encourage them to get care if they need it. We, along with colleagues across our health system, have been pushing out messages using our electronic health record, and we certainly are pleased to participate in these public service announcements aimed at trying to convince people that there are more diseases out there than SARS-CoV-2 that can adversely affect their health at this moment in time. I hope the cumulative impact of those things is positive, but clearly the fear associated with this virus is very real and is going to take some time to be overcome.
Looking forward to what I hope is some brighter days ahead, I'm interested in what you're all doing to prepare your organizations for re-emerging from the surge, based on what you think has going on, what you think is going to stick, what you think is going to change, and perhaps what's not going to change. What are your plans for how you're preparing for delivering care in the future? Dr. Fernandez?
Thanks, Greg. We are in very, very detailed mode of planning. Let me hit on the outpatient areas, and I'll leave it to my colleagues to talk about the inpatient. On the outpatient, there's been a lot of decrease in volume. I think we'll be very ready to see all those patients, trying to think of creative ways to keep social distancing, as well as dealing with the PPE. But social distancing, one of the ideas we have in some of our suburban sites is that people can use the parking lot as a waiting room. So I think we have to reimagine how we treat patients, but also how we organize them and have them come just in time to their visit so we can protect both our staff and our patients. But this will be it's a big challenge. It's actually harder to recover from this than it was to downsize, especially in our ambulatory areas.
Dr. Slavin, your thoughts about this re-emergence?
Yeah, I agree with John that I think re-emerging in many ways is more complicated than sort of building the capacity to care for COVID-19. It's clearly we're going to be caring for patients with COVID-19 for the foreseeable future, and we're going to need to do a delicate balancing act related to several key resources between the COVID-19 and the non-COVID-19 populations, balancing our inpatient and outpatient capacity, balancing PPE, and maybe the most complicated aspect of all, balancing where our staff is deployed. We and colleagues across our health system have deployed thousands of staff from their usual clinical activity to be on the front lines of battling COVID-19. And as we reopen our inpatient and outpatient activities to other sorts of patients, how we repatriate those staff to their original site and yet not disrupt our care of COVID-19 patients is a very challenging logistic matter. So we're starting today caring for patients who we've deferred for certain outpatient surgery and inpatient surgery for that matter, patients that we thought could wait a matter of weeks but can't really wait any longer, like patients with breast masses, thyroid masses. Those things need to be treated sooner rather than later, and so we're starting this balancing act as we speak today.
Dr. Nabel, as you're thinking about this reimagining and recovery for Brigham Health, how are you approaching things?
Well, thank you, Gregg. We are really thinking about almost like a zero-based budgeting, really zero-based, let's build from the ground up. Let's use this crisis as an opportunity to think bold and think differently and really implement those changes that we maybe have wanted to do all along, but just didn't have the courage to do so. And so for the past 3 or 4 weeks at the Brigham, but also across Mass General Brigham, we've been engaged in the recovery program. You've heard Gregg refer to it as reimagining to recover. It's the idea that everything's on the table to rethink. For us in the inpatient arena, I think the two major categories that we're thinking about are our assets and then also our workforce. So in terms of our assets, we want to be flexible and nimble, but we're thinking about where our services are performed, how our various service lines like cancer, cardiovascular, neurosciences are positioned, the use of all beds, the use of all ICUs. So, for example, historically, we've had 6 to 8 ICUs. They may be disparately located throughout our multiple buildings, and a service line may have owned a particular ICU. Well, there were disparities in terms of one ICU may be filled, but another ICU may have an opportunity to care for additional patients. So what if we aggregated all of our ICUs and allowed our physicians and surgeons to flex up and down in aggregate? That's an example. You can use the same example to our ORs and scheduling. Block time, for example, has been the domain of our surgeons for many, many years, but let's rethink about how we do OR scheduling. In addition, the same applies to our procedure rooms and even to our ambulatory assets. As we engage in using far more digital tools, we won't need the amount of ambulatory space, we don't think, and the way we use that space will change, as will our inpatient space. And then we are going to need to make tough, wise decisions on how we deploy our workforce. So right now, as Dr. Slavin indicated, many of our workforce have been working from home. We have redeployed a number of individuals. They're now working across services in multidisciplinary teams. Cancer nurses are now working in the ICU. Outpatient nurses are now working in the inpatient setting, et cetera. So we can really think about repurposing, consolidation, who needs to work remotely, who needs to work on site. Are there hybrids? We're thinking differently about talent acquisition. And then fundamentally, we know that for the foreseeable future, we will have a low level of ongoing COVID patients within the hospital. And how do we think about having those individuals cared for in a safe environment that's very separate from and distinct from our other patients? So we really will be thinking about doing things very differently, but there's no doubt that digital care will expand and be a foundation to all of the care that we deliver.
You know, one of the things that we often talk about in healthcare is the notion that we have to try to fix the plane while it's flying, because we have to always be there to deliver care when we're trying to make fundamental change. And I would say that, you know, I think all of you hit on this notion that, well, we've actually been grounded a bit. And during that time while we're grounded, we're going to take advantage of that. And one of the areas that I mentioned at the outset is the explosive growth of virtual care. And I'd really like to hear from each of you about what you think is the future of care at a distance. What is going to be the way that we deliver care in the future based on your experience of the last few months? Dr. Nabel?
Well, I think the transition to consumer-focused healthcare will accelerate. We've already gotten our foot in the water. We know that there are many startups with really creative, imaginative tools. Our information technology leadership and workforce is innovating day in and day out. So there's no doubt that this consolidation will accelerate. And I want to just take a moment to highlight that during this crisis, we did found an MGB, Mass General Brigham Innovation Center for COVID-related technology. There will be a lot of technologies coming out of that, which will lend itself to routine care as well. In addition, we have a magnificent MGB Innovation Center that you're going to hear more about today. But also, I think the focus on consumer health will mean that there are going to be more choices available. Care will be less hospital-centric. It'll be more outpatient, ambulatory, in the home in many ways. We don't even know what routine care is going to look like in the future. Will there even be a role for what we're calling a routine care in our lexicon anymore?
Dr. Fernandez, a little bit from your crystal ball about what you see as the future with virtual care.
I think it's going to be explosive. I figure if my 86-year-old father can learn Zoom in a week, there's going to be a lot of explosion of this technology. I think there'll be some exciting parts, even pre-visit and post-visit, how you do post-op visits in the OR. All those things I think will be just absolutely explosive. I think we'll have to adapt also our sites so that they become places where people get tested, images done, procedures done. Our locations will be where patients get touched. And at home, you can do it from your couch when you have a concern. And maybe this is also going to be a big help to preventative medicine so that people get ahead of the game instead of sitting and waiting for their care and then waiting a little bit too long. So I'm looking forward to the future for virtual visits and so forth.
Dr. Slavin, your thoughts about the way that we're going to be leveraging virtual care?
Thanks, Gregg. I mean, clearly we are in the midst of a terrible human tragedy, and it's tempting to look for silver linings in the midst of that tragedy. And I think telemedicine, virtual care, perhaps is the most impressive of all of those. Telemedicine, virtual care has sort of been like that plane heading down the runway for a long time, unable to get much lift. But in the last couple of months, the lift has been enormous. At Mass General Hospital, we've gone from telemedicine being responsible for about less than 1% of our outpatient visits, and today it's now responsible for 85% of our outpatient visits. And I know that experience is similar across our health system and across this country. And my sense is that both patients and providers really enjoy this kind of interaction, realize that there's a lot of things that can be done virtually. Certainly, we don't want it to completely eliminate the person-to-person contact that is so special in healthcare, but there's a lot that can be done virtually. So I never think the numbers are going to go back to 1%. Where they will settle out after this pandemic is over is only time will tell. But I think virtual care, telemedicine is here to stay in a big way.
Gregg, I also, just one more point, I'd say the virtual visit and telemedicine is a way to build the relationship with the patient, not just supplant the existing relationship. So I think the organizations that can build on the relationship with the patient, as opposed to using virtual visits as just a tool.
One of the things I think that was appropriately noted is just how devastating this incredible tragedy of this pandemic has been. And I think it's going to leave us all changed forever. But I'd ask each of you, what do you think is going to be the most lasting and fundamental change in what you do and what your organizations do as a result of the pandemic? And maybe we'll start with you, Dr. Nabel.
Well, thank you, Greg. I think what I'm going to be left with, what our leadership of the Brigham is going to be left with, is how important the doctor-patient, nurse-patient relationship is. During this time for our inpatients, we have had a no-visitor policy, which means that very sick individuals of all ages, all backgrounds, have been cared for by our healthcare teams without their family. And so our healthcare teams have become their family in many ways. One of our chaplains was telling me the other day about a patient that she cared for who was dying. And she simply went in and held the patient's hand while he was dying because his family couldn't be there. And so I think it's the human connection, the human touch, those values that we hold so dear. They will not change, but I think we will value even more the doctor-patient relationship, the nurse-patient relationship, and the power of human connection and the healing.
Mr. Fernandez?
Thanks, Greg. Let me hit on the business side of this. I think that one of the biggest impacts is going to be the economic impact to practices around this country, around the region, to hospitals. I think we're going to see a lot of change because we have to, because the economics are so bad for so many businesses, but also in healthcare. There's been substantial losses. So I think we're going to have to concentrate on how that impacts consolidation in the marketplace, changes in the way we practice. So that's something I'm keeping my eye on.
Dr. Slavin, one of the things that's often been spoken about is just how this pandemic has had a differential and devastating impact on certain populations. Do you think the way that we deal with those who are struggling to get access to health care and access to all those things that make us healthy, to food, to housing, the rest, is that going to fundamentally change? And what do you see your role and the role of your organization in that change?
For anybody who previously doubted the relationship between social determinants of health and health outcomes, I would hope that those doubts have been washed away by this pandemic. We've certainly seen in the Boston area and across the country and the world, for that matter, that disadvantaged populations have been disproportionately hit by this pandemic. More affluent populations have been able to shelter in their homes, whereas less affluent populations have had to go to work and live in crowded housing conditions, making them much more susceptible to getting infected. So one of the things that we've been doing over the last few months is working closely with the communities that we serve, communities like Chelsea, Revere, East Boston, to see how we can partner with them to help mitigate this illness in their communities. And just to focus on Chelsea, we've provided the medical and nursing care in a hotel that the city has rented to help people quarantine. We have dramatically increased the amount of testing available to Chelsea residents, and we have distributed to virtually every household in Chelsea care kits that include health information, masks, and hand sanitizer as a way to try to help mitigate this disease in that community. So community health has been a big part of what we have done. I think it's going to be an even more important part of the future for our organization, and I would hope the American healthcare system in general. We need to move upstream, address these social determinants, because otherwise the inequities that are created are so painful and so obvious that I hope that this experience will motivate us to finally do that.
Yeah, let's hope so. I think that is going to be, one of the real fundamental lessons that come out of this, and it's our opportunity to finally get serious about addressing it. I think one of the things that I'd ask everyone to think about in just the closing seconds, literally a one-sentence answer, what do you think is not going to change? Mr. Fernandez?
great care and terrific research, and I hope we find a vaccine soon.
Dr. Nabel?
Our academic values to deliver the highest quality, compassionate care to all our patients, to innovate and discover, to educate the next generation of physician and scientific leaders, and to serve our communities.
And Dr. Slavin?
And I would just say the commitment, expertise, compassion of our staff, will only be reinforced by what they've been through over the last 2 months.
Thank you so much to our panelists. Thanks to all of you for tuning in and joining us here today.